So, um, if you wanted a medical procedure that actually carried the risk of cutting off the blood supply to your most sensitive anatomy, like causing the tissue to literally suffocate and die, you would probably want, a highly trained surgeon.
Right, yeah. In a completely sterile hospital setting.
Exactly. So why are thousands of people having this exact procedure done in, like, Airbnbs or hotel rooms or even garden sheds?
I mean, it sounds totally absurd when you frame it that way, but that is the very real, very dangerous paradox we are looking at today.
Yes.
The cosmetic industry just has this remarkable talent for taking invasive medical interventions and, packaging them as casual afternoon self-care.
It's wild. Well, welcome to this custom-tailored deep dive designed specifically for you. Our mission today is to cut through that glossy, social media-driven marketing and strictly examine the medical realities of a massively trending cosmetic procedure.
And we are looking at labial fillers today.
Right, which you might have seen marketed online as labia puffing or vaginal fillers.
Yeah, and we are pulling from an incredibly diverse stack of sources to do this. We've got official reports from the UK Parliament, clinical guidelines from the NHS, medical training manuals, and, we're contrasting all of those with the promotional materials from aesthetic clinics ranging from Beverly Hills all the way to Dubai.
It's a fascinating stack of information, but to even begin to understand the risks, we really have to understand the motivation first. Like, why are women seeking out injections in such a delicate area?
Well, the sources point out that this isn't purely about chasing some idealized designer aesthetic, though. I mean, that psychological pressure definitely exists.
Oh, absolutely.
But for many, it's actually about a loss of physical volume, specifically volume loss in the labia majora, the outer lips of the vulva.
Kind of like the fat pads in our cheeks, right?
Exactly like that. The tissue there naturally thins out and loses its elasticity over time. And this can be driven by a drop in estrogen during menopause or the physical trauma of childbirth or just, simple aging.
Right. And there is a much more modern catalyst driving this trend right now, too. Some of the clinic websites are actually using this term, Ozempic vagina.
Yes, that's become huge.
Right. Because when a patient experiences massive medically induced weight loss, they don't get to choose where the fat melts away.
No, they don't.
And the sudden deflation of that localized tissue can be, well, quite drastic.
It is. And when that tissue deflates, it essentially stops performing its primary biological function, which is protection.
Okay, so that brings us to the highly functional motivation for this procedure.
Yes, some sources actually refer to it as sports vagina.
Which is such a descriptive term.
Right. When the outer labia loses its natural padding, women can experience severe, sometimes really debilitating chafing and discomfort during high-friction activities.
Like cycling or horseback riding?
Exactly. Or, honestly, even just wearing tight athletic clothing.
I mean, that sounds like a completely valid physical disruption to a person's daily life. I can easily see why someone would want a fix for that.
Oh, totally.
But the issue we need to tackle today isn't their motivation. The issue is that the proposed solution, injecting foreign substances into one of the most vascularly complex areas of the human body, is marketed as this 15-minute lunch break fix.
With zero downtime, supposedly.
Right. Which is medically indefensible.
Completely.
Yeah.
The substances being used, mostly hyaluronic acid or occasionally calcium hydroxylapatite or even fat transfers, they're essentially dense gels.
And injecting a dense gel into an intricately wired, highly sensitive organ is the furthest thing from a spa day.
It really is.
Okay, let's unpack this. If you go in for this procedure, what is the baseline? What is your body actually going to do in the immediate aftermath, assuming nothing has gone catastrophically wrong?
Well, according to the clinical data in our sources, temporary swelling is almost guaranteed. I mean, it happens in about 80% of cases within the first 24 hours.
80%?
Yeah. And minor bruising affects roughly 15% of patients. The area is going to be red, tender, and you will feel this persistent, dull ache.
I've always thought of swelling as a sort of internal cast, like the body actively dilates the blood vessels in the area to flood the tissue with plasma and white blood cells.
Right, yeah.
Essentially turning the tissue into a temporary fluid splint to protect the trauma site.
Yeah.
Does that make sense?
That is a perfect way to visualize it. That fluid splint is literally your immune system responding to the micro-injuries caused by the needle and, the sudden presence of a foreign gel.
And how long does that usually last?
This acute inflammatory phase usually takes 3 to 5 days to resolve. And during that window, the behavioral restrictions are intense.
Like what?
You cannot expose the area to heat. So no saunas, no hot baths, no alcohol because that thins the blood, and absolutely no strenuous exercise.
But the restriction that completely shatters that lunch break illusion is the timeline for physical intimacy.
Yes, that is a big one.
Because some of these clinical sources state that patients must avoid sexual intercourse for up to 5 to 7 weeks to prevent trauma to the area.
5 to 7 weeks. Yeah, the tissue requires significant time to integrate the filler matrix without it being displaced by friction or pressure.
I mean, if you're listening to this and thinking, wait, 7 weeks of recovery for a lunchtime tweak? It really puts the marketing into perspective.
It definitely does.
But it also begs the question, while that fluid splint is active, how does a patient know if the construction crew is doing their job or if they've completely derailed the project? Like, how do you know if you're developing an infection?
It's really all about the nature of the pain and the environment.
Yeah.
Infections in this region are relatively rare if proper protocol is followed, but when they do happen, they are aggressive.
That's terrifying.
Yeah, so if that dull expected ache escalates into severe throbbing pain, or if the area feels hot to the touch, or if you develop a fever that is no longer standard vasodilation.
That's a bacterial infection.
Exactly. And we have to remember the geography we're dealing with here. Injecting a cheekbone is one thing.
Yeah.
Injecting the pelvic region is entirely different.
Right, because the crucial distinction is the type of tissue. Your face is covered in keratinized skin, which is this tough, layered armor designed to keep the outside world out.
Exactly. But the labia majora transitions into delicate mucous membranes.
And mucous membranes are highly absorptive, they're naturally moist, and they harbor an incredibly complex, localized microbiome.
Right. So if a practitioner isn't perfectly sterile, they aren't just pushing bacteria into tough skin. They are planting it deep beneath a delicate, moisture-rich membrane where it can just thrive.
Which is why the clinical environment is absolutely paramount.
Precisely.
Okay, so let's say a patient gets past those first few weeks. The fluid splint goes down, there's no infection, the tissue integrates. Are they in the clear?
You would hope so, but no.
Because the sources detail a whole category of intermediate complications that suggest otherwise. And what strikes me is that these complications directly attack the very reasons the patient got the procedure in the first place, aesthetics and sensation.
Yes. This brings us to the mechanical behavior of the filler itself. You are placing a mobile gel into a dynamic, gravity-affected area.
It means it moves.
It moves. One of the most common issues is uneven distribution, which results in severe asymmetry. We also see what is called inferior migration.
Inferior migration?
Yeah, over time, the constant pull of gravity and just the physical movement of the legs can cause the gel to slide downward, pooling in unintended areas.
Ugh, that sounds incredibly uncomfortable. But the sources also specifically mention the formation of hard lumps. They use terms like granulomas and dons.
Right, delayed onset nodules.
Yeah. How does a soft, pliable gel turn into a hard lump beneath the skin?
It is a fascinating, if really frustrating, immune response. Sometimes weeks or even months after a perfectly sterile injection, your immune system suddenly just stops tolerating the filler.
It just changes its mind.
Basically. Macrophages, those are the body's cleanup cells, they try to digest the gel, but they can't. So the immune system decides to wall off the foreign invader. It wraps the gel in dense, fibrotic scar tissue.
And that creates a hard, sometimes painful nodule.
Exactly.
And what role do biofilms play in this? Because the medical manuals warn about them extensively.
Biofilms are microscopic nightmares. Sometimes a tiny colony of bacteria manages to stick to the surface of the filler deep beneath the tissue, but instead of causing an acute fever-inducing infection like we talked about earlier, they secrete this extracellular polymeric substance.
Which is what exactly?
It's basically a microscopic layer of slime.
So they build a fortress on the gel.
Exactly. They build a slime fortress. And that matrix acts as a physical shield. Oral antibiotics simply bounce right off it.
Wow.
It creates a chronic, low-grade inflammation that is notoriously difficult to eradicate without physically removing the filler itself.
See, I want to push back on something we discussed earlier regarding sensation and the sports vagina motivation. The whole point of injecting this filler is to add cushioning to stop the pain of chafing.
Right.
But the clinical observations note that if a patient receives too much volume, they can actually experience severe pain during sexual intercourse.
Yes, that's a huge issue.
If the goal is cushioning, how does adding more cushioning make it hurt worse? That feels entirely contradictory.
It does seem counterintuitive until you look at tissue tension. Think of it like this. If you overinflate a balloon, the rubber becomes tight and rigid.
Right, it's ready to pop.
The same thing happens to the mucous membranes. If a practitioner overcorrects and injects too much volume, it stretches the tissue unnaturally taut. So instead of a soft cushion, you have a highly pressurized surface.
Oh, I see.
And any friction against that taut surface aggressively fires the nerve endings, completely defeating the functional purpose and causing intense pain.
Okay, so if a patient ends up with hard lumps or asymmetrical results that make intimacy painful, are they just stuck with it until it wears off? The clinics heavily advertise an undo button, an enzyme called hyaluronidase.
What's fascinating here is that they do advertise it as an undo button, but the biological reality is far messier.
Isn't it always?
Right. Hyaluronidase is an enzyme that specifically breaks down hyaluronic acid. Chemically, it cleaves the bonds holding the synthetic gel together, turning it from a thick paste into a watery liquid that your body's lymphatic system can flush away.
I mean, that sounds like a magical failsafe. What is the catch?
There are several catches. First, it only works on HA. If you received calcium hydroxylapatite or a fat transfer, that enzyme does absolutely nothing.
Good to know.
Second, there is a risk of severe allergic reaction to the enzyme itself. But the most distressing catch for the patient is the aesthetic aftermath.
What happens?
When you rapidly dissolve a large volume of filler, the stretched tissue doesn't instantly snap back. It often leaves the area looking deflated, wrinkled, and structurally worse than before the initial procedure.
Yikes. So if you're listening to this and thinking, well, I would simply go to a highly reputable, board-certified plastic surgeon and avoid all of these structural issues, you are making the right choice.
Absolutely.
But you are in the minority. Here's where it gets really interesting and honestly genuinely chilling. We are looking at an industry that operates as a regulatory Wild West, according to the sources from the UK Parliament and the NHS.
The statistics from the British College of Aesthetic Medicine are just staggering. They reported that 59% of all the filler complications they treat, the infections, the nodules, the asymmetries they originate from, treatments performed by unregulated beauticians.
59%. These are highly invasive subcutaneous medical procedures being treated like a casual manicure.
Yeah, they are taking place in hotel rooms, in basements, in unlicensed salons.
And this brings us to the most catastrophic risk of all. When an untrained person holds a needle in this region, they aren't just risking a lumpy aesthetic, they're risking the patient's flesh.
We are talking about vascular occlusion. It is the absolute worst-case scenario in aesthetic medicine.
To understand why this is so terrifying, we really have to visualize the anatomy. The pelvic floor and the genital region are sustained by a massive, densely packed, incredibly intricate network of arteries and blood vessels.
Yeah, it's a very crowded area.
If a trained surgeon is navigating it, they understand the depth and location of those vital supply lines, like a transit system.
Exactly. But an unregulated practitioner doesn't have that anatomical roadmap. If they blindly push a needle into that region, they risk injecting the thick, viscous gel directly into an artery.
I read a description of this once that compared it to a train blocking a tunnel, but that doesn't quite capture the physics of it.
Not really.
That's more like hydraulic pressure. You are injecting a thick paste into a tiny, confined biological pipe. The gel acts like a concrete dam, instantly blocking a rushing river.
That is exactly the mechanism.
The blood simply has nowhere to go.
Nowhere. And the immediate result is that the tissue downstream from that dam instantly starves. The very first clinical sign is skin blanching. Yes. The area turns stark white or pale, mottled bluish-gray because all oxygenated blood flow has ceased entirely. And this is usually accompanied by intense, excruciating pain that is completely disproportionate to a normal injection ache.
And if the practitioner doesn't recognize that blanching immediately, if they don't immediately flood the area with that dissolving enzyme to break the dam, what happens to the starved tissue?
It undergoes necrosis. The cells die, and the flesh literally begins to rot away.
Wow. The UK Parliament report highlighted a truly tragic case that brings all of these systemic failures into sharp focus. We need to discuss the case of Sasha Dean.
Yeah, Sasha Dean's case is a horrific example of what happens when large volume fillers meet unregulated practitioners.
What exactly happened to her?
She went in for a liquid BBL, a non-surgical Brazilian butt lift, which involves injecting massive quantities of dermal filler into the glutes and the pelvic region. And it was performed by someone with zero medical qualifications in a non-sterile home environment.
And the outcome wasn't just a localized reaction.
Yeah. No, it was much worse. The bacteria introduced during the procedure entered her bloodstream. She went into septic shock, which is a life-threatening systemic organ failure response.
Oh my God.
She was actually placed in a medically induced coma for 5 days, and she was left unable to work for an entire year as her body tried to recover.
Her story really underscores the severe limitations of our medical safety nets. Because when massive vascular occlusion or deep tissue necrosis occurs below the belt, you cannot just inject an enzyme and apologize.
No, you can't. The dead necrotic tissue must be physically cut away. Surgical excision is required to save the surrounding healthy tissue, and that leaves the patient with permanent, profound scarring and disfigurement.
It completely shatters the illusion of the casual cosmetic tweak. You are essentially playing Russian roulette with your vascular system if you allow an unqualified person to wield that syringe.
The stakes are incredibly high. Comprehensive surgical-level anatomical knowledge isn't a luxury. It is the fundamental prerequisite for safely navigating that region.
Okay, let's pivot for a moment and assume the absolute best-case scenario. You do your research, you go to a board-certified professional in a pristine, sterile clinic. They navigate the vascular network perfectly, you avoid the biofilms, the fluid splint goes down normally, and you get the exact functional cushioning you wanted.
Sounds perfect.
You're set for life, right?
Unfortunately, no. And this is a reality that catches a lot of patients off guard. We have to look at the long-term biological reality of labia puffing. Fillers are not implants. They are not permanent structural changes.
Right, because the body actively metabolizes the gel.
Correct. Your body produces its own natural hyaluronidase enzymes that slowly, systematically chew through that injected hyaluronic acid.
So how long does it actually last?
On average, you can expect the functional and aesthetic results to last anywhere from 6 to 12 months, perhaps stretching to 18 months depending on the specific density of the product used.
And that timeline isn't even a guarantee. The sources point out that the speed of the breakdown depends heavily on the patient's individual physiology and lifestyle.
It really does.
Like, if you got the procedure because you are an avid cyclist or runner, meaning your heart rate is frequently elevated and blood flow to the pelvic region is high, your body is going to metabolize that filler significantly faster.
Which creates a fascinating dilemma. If you want to maintain that protective cushioning, or if you want to maintain the volume, you are committing to a relentless cycle of repeat injections.
So what does this all mean? It means that cycle comes with a heavy financial burden. Pulling data from the aesthetic clinics in Dubai, a single session can cost around 2,999 dirhams, which is roughly $800 US.
That adds up fast.
Yeah, when you multiply that once or twice a year, indefinitely, it becomes a major recurring subscription.
But the financial cost pales in comparison to the recurring medical risk. And before we discuss the nature of that recurring risk, we really need to address who is entirely disqualified from entering this cycle in the first place.
Right, the contraindications.
Exactly. The medical contraindications for this procedure are incredibly strict.
Obviously, it is universally unsafe for anyone who is pregnant or breastfeeding. But the sources also specifically call out autoimmune disorders. Let me make sure I understand the mechanism there. Is it because their immune system is already hypervigilant?
Exactly. A patient with lupus or rheumatoid arthritis has an immune system that is constantly looking for a fight.
Right.
If you introduce a foreign synthetic gel into their tissue, the likelihood of their body attacking it, walling it off, and forming those painful granulomas skyrockets. It is a completely unnecessary provocation of their immune system.
There was another contraindication in the clinical manuals that caught my eye,
Yeah.
and it has to do with viruses. They explicitly warn against performing this on patients with a history of genital herpes simplex. How does a needle interacting with a gel trigger a viral outbreak?
It comes down to trauma-induced viral shedding. The herpes simplex virus lies dormant in the nerve ganglia. It is essentially sleeping.
Okay.
When a practitioner repeatedly pierces the delicate mucosal tissue with a needle, that physical trauma sends distress signals through the local nervous system.
And that wakes it up.
Exactly. That trauma can shock the dormant virus awake, triggering a severe, intensely painful, localized outbreak. It is such a recognized risk that responsible clinicians often prescribe prophylactic antiviral medication prior to the procedure just to suppress the virus.
Oh. Which brings us back to the best-case scenario patient, the one who avoids all the immediate risks and loves the result. Why would they choose a temporary gel over a permanent surgical solution? Let's briefly contrast this with surgical labiaplasty.
Surgical labiaplasty is a permanent alteration. The surgeon physically cuts away and removes the excess or stretched tissue. It requires general anesthesia, significant downtime, and it permanently alters the architecture of the vulva.
And it carries its own terrifying set of permanent risks. You can experience permanent nerve severing, leading to a total loss of sensation. You can suffer from chronic dryness.
Yes.
Or you can experience over-resection, where the surgeon simply removes too much tissue, completely eliminating the protective barrier and causing lifelong pain during intimacy.
If we connect this to the bigger picture, when a patient weighs the potential for permanent nerve damage and irreversible surgical mistakes against a temporary gel injection, the filler seems infinitely safer. It feels like a low-commitment trial run.
But that perceived safety is exactly what lures them into what we can call the maintenance trap.
That is a perfect term for it. Because the filler is temporary, you have to go back. And every single time you return to the clinic for a top-up every 6, 8, or 12 months, the needle has to break the skin again. The gel is introduced again.
And every single time that needle goes in, the odds reset. You spin the roulette wheel of vascular occlusion, of bacterial biofilms, of severe inflammatory responses all over again.
Yes, you do.
You don't just survive the risk once. You are exposing yourself to catastrophic anatomical failure annually for as long as you wish to maintain the result.
And that compounding cumulative risk over a lifetime is something the glossy Instagram marketing materials will never explicitly tell you.
We have covered a tremendous amount of physiological and medical ground today. Let's pull this all together. It is undeniable that for many women, labia puffing provides very real, legitimate, functional relief from chafing, as well as a restoration of aesthetic confidence after major life changes. The motivations are deeply personal and entirely valid.
They are. But recognizing the validity of the why does not excuse ignoring the danger of the how. Treating the injection of foreign gels into highly vascularized mucous membranes as a casual beauty treatment is medically negligent.
Absolutely.
It willfully ignores the severe realities of tissue necrosis, chronic biofilms, and the heavy physical burden of continuous maintenance.
If there is one ultimate takeaway for you listening to this deep dive, it is this: your anatomy is uniquely, complexly yours. It is an intricate ecosystem.
Any decision to alter that ecosystem, particularly in an area so rich in blood vessels and nerve endings, requires the expertise of a board-certified medical professional operating in a strictly sterile environment. You cannot bargain hunt for invasive procedures. The physical cost of a mistake is simply too devastating.
Which brings us back to that initial paradox. We want our medical interventions to be simple. We want a clean x-ray, a quick syringe, a 15-minute fix that lets us get back to our day. But human biology fundamentally resists that kind of simplicity.
Biology is never just a transaction.
So as we wrap up, I want to leave you with a final thought to mull over. As medical science makes it faster, easier, and more accessible to superficially alter our most hidden, intimate anatomy, the friction between what we can do and what we should do is only going to grow. At what point does the psychological and cultural pressure to achieve a perfectly smooth, idealized physical aesthetic outweigh the compounding, terrifying physical risks we are willing to subject our bodies to?
It is a profound, deeply personal calculation, and it is one that every individual must honestly reckon with long before they ever let a needle break their skin.
Until next time, keep questioning the surface and always look deeper.